Kia ora and welcome to Goodfellow podcasts. This episode is kindly supported by an unrestricted educational grant from Mercy Ascot. The content of this podcast was developed independently and the views expressed are those of our expert speaker. I'm Dr. Louise Kugler, a specialist GP, and today I welcome to the podcast Dr. Christine Goh to discuss the two most common congenital chest wall deformities, pectus excavatum and pectus carneanatum. Christine is a consultant cardiothoracic and transplant surgeon who has been trained in both Australia and New Zealand. After training, she completed her 2-year fellowship in heart and lung transplantation and minimally invasive cardiac and thoracic surgery in Sydney. Christine works at both Auckland and Mercy hospitals, and she provides comprehensive cardiac and thoracic surgical management and tailors the treatment to her individual patients. Kia ora, Christine, and welcome to the podcast.
Oh, thank you, Louise. Thanks very much for having me today. It's a privilege to be talking about some of the common congenital chest wall deformity.
So on that, Christine, tell us how prevalent are congenital chest wall abnormalities and what are the two most common types?
Yeah, sure. The congenital chest wall abnormalities are relatively common, actually. And through the literature, the precise prevalence really vary depending on the specific condition as well as the population that was studied. But in general, the two most common types of congenital chest wall deformities are pectus excavatum and pectus carinatum.
So you've mentioned pectus excavatum or funnel chest. This is more frequently encountered. Can you paint a picture of what this abnormality looks like for our listeners?
Yeah, really pectus excavatum, probably most of you have come across to some patients. It is also known as a funnel chest. The appearance is really a sunken appearance of the chest because of the abnormal growth of the rib cartilage. And it is characterized by a depressed sternum or breastbone. And the most noticeable feature is actually the inward depression of the sternum of the breastbone. And it gives the chest a sunken or a scoop-up look. And sometimes the depth of the indentation can vary. Some patients will just have very mild and sometimes not even noticeable, but certainly the patients that comes to us mostly have at least moderate to severe appearance. Now, because of the sunken end of the center of the breastbone, the surrounding rib cage surrounding the sternum can appear to be more prominent as the ribs and the cartilage push outward while the sternum is being recessed. So overall, the chest looks like, it's been dented or compressed in the middle, creating a hollow appearance of it. Now, the pectus excavatum can range from mild, where the aesthetic changes are minimal, to severe, where the structural changes can actually impact on internal organs and the overall function subjectively.
So can you explain the underlying causes and the development process of pectus excavatum?
It is believed to be caused by an abnormal development of the rib cartilage. And in this condition, the cartilage that connects the ribs to the sternum grows so much and excessively that sort of pushes the sternum being pushed inward. The exact cause of this abnormal cartilage growth is not entirely understood, but it is thought to be due to a combination of genetic and environmental factors. The condition often becomes more noticeable during adolescence. As the chest wall and the ribs grow, it sort of can change as the child or the children develop.
So in terms of occurrence, how common is this abnormality in children?
Oh yes, pectus excavatum is relatively common, affecting about 1 in 3 to 1 in 400 children. It is much more common in males than female with a ratio of 3 to 1.
So when a child has pectus excavatum, how do they typically present and what symptoms might they present with?
Often in the clinical setting, the children becomes noticed when, they are in school, they do sports without their shirt on and, it's either the friends pointed out they've got sunken chest or they become self-aware. So a lot of the time, it's the appearance of the chest. They suddenly find that, the chest is not quite normal. Certainly, in some children, they could potentially get some physical discomfort or pain, although many children have no symptoms. In severe cases, they might actually experience subjective exercise intolerance. So they can describe shortness of breath, fatigue, maybe because of the reduced lung capacity and potentially compression of the heart.
So which children with funnel chest or pectus excavatum should be referred for further evaluation and possible treatment?
This is an interesting question because I think all patients with pectus should really be referred for review and reassurance, because a lot of the time the parents and the children felt that they have an abnormal chest and became quite concerned of it. And certainly children with pectus excavatum should be referred, especially when the chest wall deformity is severe or progressive, and if they have significant symptoms such as respiratory or cardiac issues, if they are short of breath, they have pain. More importantly, if they have some sort of psychosocial impacts, in terms of self-esteem issues or bullying. And some patients or children can be so severely impacted in terms of their psychosocial aspect, they sort of impair the education and learning aspect of it. And a lot of time is more sort of they interfere with the normal activities and development of the children. That's actually the more important aspect of why we see those patients and to reassure them.
So in the more severe case, what are the possible treatments for funnel chest?
The treatment of funnel chest generally divided into surgical and non-surgical. This non-surgical option includes a vacuum bell. Essentially, it's a suction device, a silicone cup that creates an area of low pressure over the sunken part of the chest. Essentially, the pump sucks out the air of the device, which in turn creates a vacuum that pulls the depressed or the sunken chest and the rib outward. And it is believed that over time, this gentle pressure will reshape the chest and guides the sternum back to its normal position. The success of this treatment varies because it's probably useful in patients with mild deformity and also younger patients when the chest is more flexible and compliant. And now in terms of the surgical options, there are generally two types of surgical procedure that we can perform. One is the NASPA insertion, and one of them is the modified or ravage procedure. The NASPA is commonly performed these days. It is minimally invasive. What it does is it really corrects the pectus defect without cartilage resection by applying the outward pressure to the sternum to the point of the maximal inward deflection. And what they involve is a U-shaped bar that is placed in the pleural space and pass behind the breastbone and push the sunken chest out. Now, usually this bar is left in for a good 2 years. There is really no objective evidence to suggest how long we should leave the bar in for, but there's some literature that says that we should probably leave it until the patient turns at least 18 years of age when they stop growing. The other procedure is the modified ravage procedure, which is less commonly performed these days and is often referred to as the open procedure. It reduces the length of the elongated costal cartilages by resection, and it is more often commonly performed in a much more severe and asymmetrical pectus excavatum.
Great, thank you for that. So let's move on now to pigeon chest or pectus carinatum. What are the mechanisms behind its development?
Yeah, so with the pectus carinatum or the pigeon chest, it often occurs because of the abnormal growth of the rib cartilage again. And instead of pushing the breastbone inward, it's actually pushing the breastbone outward. Again, the exact mechanisms are less understood in pectus carinatum, but again, it is thought to be due to excessive cartilage growth and a failure of the normal remodeling of the chest wall during the growth.
So prevalence of this condition, how does this compare to other chest wall abnormalities?
Pectus carinatum is far less common than pectus carinatum. The prevalence is estimated to be about 1 in 1,500 to 2,500 children. So you can see the ratio is way less than pectus carinatum, and we don't see it often. But the common thing again with pectus excavatum is much more common in men than women.
Okay. So how is someone or a child going to present here, and what are the typical signs and symptoms that they will present when they have a pectus carinatum?
Again, same as pectus carinatum, normally they notice a chest wall deformity. They will be saying, my chest doesn't look quite right with a prominent protruding sternum. And they can also have visible rib deformities around the sternum. Sometimes they may experience discomfort, but most of the time, they don't seem to have sort of respiratory and cardiac symptoms compared to pectus excavatum.
And referral criteria, is this similar?
Yeah, similar to pectus excavatum. The sooner the patient is referred, the better, because we can review, monitor the progress, and also reassure the patient. Essentially, is whether they have symptoms, psychosocial impact, and any other cosmetic concern.
Wonderful. Well, thank you so much for your time today. To conclude our podcast, please, your take-home messages for our listeners.
Sure. So essentially, the congenital chest wall deformity is very common. The pectus excavatum is much more common than pectus carinatum or pigeon chest. The spontaneous regression is very rare, and the symptoms varies and very non-specific. The non-surgical treatments usually has limited improvement, and with surgery, there's usually high success rate with low recurrence, and most patients generally have very good satisfaction in terms of the appearance after the operation.
Fantastic. Well, thank you so much once again for joining me today.
Oh, it's an absolute pleasure. Thanks for having me.
If you're a New Zealand GP and would like to claim CPD points for listening to this podcast, our podcasts are eligible, so please log them. You'll find a list of resources used in this podcast on our website, goodfellowunit.org, and we value your feedback. So please get in touch. Email us at podcast@goodfellowunit.org. Thanks for listening.